Forearm fractures, high energy fracture, high risk of compartment syndrome, relationship with bicipital tuberosity with the radial styloid should be 180° at AP view. Relationship between the coronoid and ulnar styloid should be 180° in lateral view. Radius rotate respective to ulna. Radial bow is important. Monteggia fracture is a proximal third ulnar fracture with radial head dislocation, rare in adults. Bado classification, type 1 anterior dislocation, most common in children's. Extension type, ulna apex anterior. Posterior dislocation, most common in adults. Type 3 is lateral dislocation, and type 4 is both forearm fracture with associated radial head dislocation. Monteggia equivalence, radial neck fracture with ulnar shaft fracture, or radial head dislocation with plastic deformation of ulna, called Mubarak sign, subtle ulnar fracture on lateral ulnar radiograph. Ulna basically should be straight. If there is any bow, it's called Mubarak sign. Can try MUA to see, otherwise reduce and fix ulna. Always contemplate that plate is better than putting a nail, and needs to have optimal reduction of ulna before reducing the radial head. Most of the radial head does reduces. Immobilization in supination to relax bicep, and inflection to stabilize radial head in type 1 fracture. Type 2 Bardo, immobilization in extension, mid prone to relax the brachioradialis. Missed cases, ulnar corrective osteotomy to reduce radial head, multiple level osteotomy. Annular ligament reconstruction can be with fascial lata, hold radial head with transcapital K wires, or excise radial head if skeletally mature.